Everybody, and welcome to Neurology Grand Rounds. And I'm really happy to introduce Dr. Jason Sico, who's one of my very best top shelf friends, was a resident with me at Yale New Haven Hospital. So Jason is Associate Professor of Neurology in the Division of General and Vascular Neurology. He's also faculty in the Department of Internal Medicine. He's double boarded in neurology and internal medicine. And he's also the director of he's the inaugural director of the new VA Headache Center of Excellence program that's being established. And so we're looking forward to interacting with him on that specific area here in Seattle. So Jason's from Pennsylvania. He went to the University of Scranton and then medical school at Temple before joining the internal medicine program for internship at Yale New Haven Hospital. And then he did his neurology residency. In the middle of his neurology residency, he always has a deep and broad interest in medicine. And so he opted to return and get additional training in internal medicine to qualify him for the boards before returning to neurology and completing that. He's joined the Yale faculty and worked at the West Haven VA and been involved with numerous projects. He's been PI and co-PI on many different funded studies. He's also an extremely active member in the AAN. He's served as on several committees, the Advocacy and Medical Economics and Management Committees, the Health Services Research Subcommittee, and the Members Research and Health Policy Subcommittees. And, you know, hearing Jason's and looking at his CV for sure, he's been pretty broad, nearly schizophrenic interests, and that could surprise people. But it doesn't mean he's always had this broad interest, and it was reflected in his mentors when we were resident. Larry Brass and Don Bravata really supported and taught him a lot about stroke and encouraged his efforts in that area. He also had close mentorship relationship with John Booth, the former national director of neurology within the VA. And everybody in the neurology residency program, since he was there, has benefited from Jason's effort to establish a neurology consult clinic in the Nathan Smith Clinic, which is the HIV and infectious diseases clinic at Yale. And that was a spectacular experience, getting to see some of these complications of therapy in HIV patients, as well as from their infectious disease. So Jason, it's great to have you here, and thank you for coming to speak to us.
Absolutely. Great, Chris. Thanks you for that kind introduction. And also, again, thank you for the invitation to come to speak with everyone. I very much appreciate it. And as Chris mentioned, it's been really sort of a wonderful experience to be able to combine neurology and internal medicine in such a way that to bring about really sort of meaningful change. And Chris had sort of mentioned some of the mentors that I've had, and definitely want to pay them homage as we talk about how we in our shop and throughout VA have used both big data, little data to understand the current state of care quality and delivery within the VA, recognizing that the VA embraces the tenets of a learning healthcare system. Some of the things that we'll do during the course of our talk, we'll discuss what a learning healthcare system is, and then how we've used those tenets, as well as leveraged the really fantastic data sets and capacity of VHA to be able to improve care quality for some of the most disabling neurologic conditions, headache in younger folks, and then stroke in older people. Here's some of my financial disclosures. So I currently have a HSRD Merit Award, being able to look at testing and treating sleep apnea, not just sort of with randomized controlled trials at the patient level, which we've done 3 over the last 15 years, but being able to randomize entire medical centers to change their workflow to identify these patients. Then also I along with the Headache Centers of Excellence program, there's a concomitant research and evaluation center. And then we have another HSRD funded trial regarding the telehealth delivery of behavioral interventions. So another thing, so after leaving the house that I rented on the water, which Chris remembers some of those, Imres remembers some of those, the barbecues that we had. So moved up the shoreline, got married, had kids, white picket fence, as you can see there, and became a chicken owner. So It's always really fantastic to be able to speak among friends. And as Chris had mentioned, we've known each other since 2004. And typically, whenever I give a grand rounds or talk at friends' institutions, you'll ask, is it okay to include some pictures? And is it fine? And then usually some of the stipulations being that they can't be incriminating, overly embarrassing, or otherwise sort of, not kosher. So look back at another picture that I had of Chris and I together, and none of those fit those bills. So hence the blank picture here. But I'm like, well, Chris really sort of helped me along the way. So this is what we looked like. So this was the size of our residency program. So I was the half resident in our program because, as Chris had mentioned, every 6 months I would leave neurology and go to internal medicine. But then Chris taught me most of what I know in terms of playing pool. And also Chris taught me the value of doing house visits to patients. So this is a very low tech. So this is a picture of a Polaroid for one of Chris's and Joe Schindler's patients. And that is indeed a Marilyn Monroe cutout. Chris probably still had that driver. So again, during the course of our discussion today, I really want to be able to outline some of the tenets of a learning healthcare system, how we use those specifically for veterans getting care in VHA, and understand sort of different types of information to understand the composite about care quality and care delivery. And we're going to do that in the context of one query via query project called Prevent, which we completed a couple of years ago, and how we've been trying to incorporate big data and little data in terms of rolling out a national program to improve headache care. So as Chris had mentioned, some mentors that that really meant a lot to me and still continue to mean a lot to me. And both Sir Larry Brass on the left and Sue Tepper on the right have, one of the things that I gleaned from them is how do we bring things to an individual patient? How do we help that N of one, that one person in front of us, that one family? So as Chris had mentioned, Larry Brass was a world-renowned stroke neurologist. He was my very first stroke attending, very first neurology attending. And one of the things that he sort of instilled in terms of being able to be both patient-centered and guideline concordant at the same time, but also doing so in such a way that we learn from our patients every single time. And some of the best clinical questions that came that Larry had helped answer and published in New England Journal and broadly came from patients in the clinic. So how does our work with stroke patients, how did the work that we do, yes, it absolutely should benefit the person in clinic, but are there ways by which we could think about how it could benefit an entire clinic or patients like them, entire healthcare systems like them that care for these patients? So on the right, Sue Tepper is a headache neurologist that used to be in Connecticut. He's now further up in New England after spending some time in Cleveland. He would come to lecture to us on a monthly basis and really had a passion for headache and ran and continues to run clinical trials. But both of these have sort of taught me, how do we take that clinic visit and how can we sort of think more broadly about helping people on a grander scale, if it's through health services and epidemiologic work or clinical trials. So again, like how do we sort of take that one person and how do we, again, understand how to help many by helping that one? But then also realizing that that one person gets healthcare either at a one clinic or one provider or one healthcare center. And I think in the VA, we're especially in tune with the idea of medical centers and healthcare systems. So, but if we could learn at one place, what could we extrapolate? What could we spread to other healthcare systems or other hospitals or facilities, recognizing that there's a multitude of different people and different types that get care within facilities as well as across a healthcare system. Which brings us a little bit to the concept of a learning healthcare system. So the IOM and others have introduced and expanded on this topic, but it's really sort of a healthcare system, if you will, that integrates science, informatics, culture, such that we can learn from every single N of one, so that continuous improvement and innovation is built in to high quality care delivery. And this could happen in any type of work unit, if it's in a clinic, in an entire ward, if you will, but it could be national or international. And some of the other things behind learning healthcare systems is that it really sort of helps to generate and apply the best evidence for what we need to do for our patients when we're seeing them in a collaborative way, such that there's also sort of patient and provider-centric choices that need to be made for caring for someone with any given healthcare condition. But really, again, we learn from our patients. These healthcare systems learn in such a way that's a natural outgrowth of what we're hearing from our patients, but doing so in such a way that we provide high value care, that's high value, high quality, safe, and innovative. And again, being able to sort of balance and incorporate personalized care plans into what we know to be best practice, but also recognizing that every single time we see someone, there's a chance to collect data and get information in terms of how we could do better as providers and healthcare systems. So some of the ways by which a healthcare system goes to a learning healthcare system, really keep in mind, how do we improve quality? How do we understand cost and complexity? But also in this day and age, how do we be and stay competitive? So I want you to keep some of that in mind as we sort of discuss a couple of different projects, one stroke related and then one headache related. So I think many of you sort of well know that the VA is the largest healthcare system in the United States. There's more than 170 medical centers, more than 1,000 outpatient clinics, and it serves more than 9.1 million veterans every single year. So whenever I'm with residents, fellows, learners, one of the things I have joked about is every time we're at a computer terminal and we're at CPRS, really the VA becomes almost like the world's largest database, where, as you well know, every time we put in an ICD code, a CPT code, medications, even unstructured data, i.e., or EEG, excuse me, notes, radiology reports, all of those are fair game, and they're things that we could use to understand the current state of care quality and understand associations between illness and outcome and within disease states. So it's really fantastic to be able to look at really millions and millions and millions of data bits, but then also kind of recognizing that how do we take that to a 30,000-foot view and how do we bring it down to a given person? And really, I think with big data, some of the things that we could understand in terms of what is care quality. In this case, we'll say the Veterans Health Administration, but it also allows us to interview and survey individual people, their family, to again understand the current state and what we could do to make a better healthcare experience. So some of the things that help with this transition as healthcare systems go to learning healthcare systems, really being able to sort of recognize what are the existing strengths and building on those. Sometimes that also means identifying gaps in strength and developing training programs or bringing in outside expertise, having strong leadership that really sort of believes in this mission, being able to understand and measure quality in a really meaningful way, but then also being able to have it such that data capture from health encounters becomes both purposeful and hopefully seamless, so that it does integrate into what we do both in clinical practice, quality improvement, and research. So one way to sort of to conceptualize and think about care quality is the DMBA model, where what are the structures that are in place that a healthcare system has to be able to deliver healthcare? What are the processes by which care gets into the hands of patients? And then what's the outcome of those care processes? So I do a fair amount of thinking as the bubble sort of suggests, and some of the things dating back to spending time with Larry Brass and continuing to work with Don Bravada is getting a sense of, well, what is the quality of care that VA is giving to patients with a cerebrovascular event? So some of the things that we did to help understand this is using big data, and we took things from the Joint Commission stroke core measurement set, as well as the AHA, ASA performance measure set, and we developed electronic quality measures. So this whole process took about 5 years to develop them, validate them, and then understand potentially the wide applicability. But also at the time, there weren't any official TIA electronic quality measures. So we adapted and used what was available in the Joint Commissions and AHASA and apply them to TIA. And with these electronic quality measures, the thing that we do on a fairly regular basis, or should be doing for patients that come in with a new cerebrovascular event. Do they get a picture of the brain as necessary? Do they get carotid imaging? And really understanding sort of stroke etiology, as well as understanding the risk factors. but also being able to do things that we know helps to improve outcomes. So then with every process, people are either eligible and they passed it, eligible and failed it, or they were ineligible. So in a lot of ways, the VA is doing quite a fantastic job sort of across the board in terms of with a lot of the electronic quality measures. So sometimes when it comes to QI work, we think about 80% or more is a really good benchmark to really try to get a lot of these processes sort of in place, and meaning that it also sort of does good things for our patients. So the VA has been really great in terms of making sure that when applicable, people are getting antithrombotics and they're getting brain imaging, they're getting the A1C measured, and they're on anticoagulation if they need to. A smidge less than that, but still not so bad, is making sure that people get the appropriate DVT prophylaxis, and the blood pressure is controlled, at least when we did the analysis at the older go of less than 140/90. Then we start getting at areas of other improvement and across the board. Being able to, getting a neurologist involved in these patients within the first day and getting an echo and carotid imaging. But then even something that seems like would be fairly straightforward in terms of making sure that someone's discharged on the right statin had been occurring at lower facility level rates. So then some of the things that we wanted to do is that we rank facilities using hierarchical linear modeling and get a sense of, on a composite, what medical centers are doing a really good job, what centers weren't doing as great, so that we could go there and learn from people on the ground and in the clinic, interviewing neurologists, primary care providers, hospitalists, quality management personnel. So over the span of 9 months, we conducted more than semi-structured interviews with people that are really knee deep in helping veterans improve their risk factors, as well as understand why someone had a cerebrovascular event in the first place. And then we also wanted to focus on what are some of the barriers to providing care, what are some of the things that work well or facilitate care, but also we asked about specific and potential interventions. If we focus now a little bit in terms of post-stroke hypertension management, one of the themes that came out was this, the idea of sort of ownership of care. So it seemed as if, surprisingly, there was not just lack of ownership in terms of who was supposed to manage the blood pressure. So one of the things we heard from neurologists time and time again is that hypertension is squarely in the purview of the primary care provider. When we talked with the primary care providers, they would say, geez, I think the neurologist manage or co-manage blood pressure just like the cardiologist do for post-MIs. And the neurologist consistently said things along the lines of, not only is that the primary care responsibility, but it's also like, I have faith, I believe that they're doing it. So mind you, again, this is providers that are on the same electronic health record system, so that they're able to see whether or not these things are or are not occurring. One of the other themes that we heard pretty consistently from primary care providers is this idea, one that we as neurologists well know, in terms of cerebral autoregulation, and really hesitancy to start or even titrate blood pressure medicines anytime after they've had event. And some of the things that we heard was even 6 months, 9 months after someone's had a stroke or TIA, this concern about starting or up titrating blood pressure medicine because of fear that autoregulation was still off kilter, if you will. Some folks sort of look towards sort of facility level processes and structures, saying, well, there's really no processes to help sort of facilitate care, work with care transitions, develop handoff between inpatient providers, outpatient providers, and that could be inpatient neurologists or hospitalists, and who's responsible for what type of care within the healthcare system at what point in time. Also, providers noted that blood pressure control really wasn't necessarily a priority for patients. So really, patients would oftentimes prioritize other things like back pain or neck pain or other things before even wanting to address their high blood pressure. So you take sort of all these Venn diagrams, and it's almost as if there's this sort of watershed effect in a lot of places in terms of managing post-stroke blood pressure control. And we found that this is very similar to managing other risk factors as well. So one of the things that we thought about, and we all know that changing culture is hard for given healthcare providers, but how could we use this information to say, okay, well, are there areas where a healthcare system could sort of buttress and recognize that there is this watershed effect? So next, with that in mind, some of the things we wanted to ask next, going back to big data, are if there were processes of care that were associated with reduced risk of mortality, as well as recurrent cerebrovascular events. So, and again, we use some of the electronic quality measures that we had developed before, but we also wanted to make sure that they were things that, should they be found to have outcome benefit, could be widely implemented across healthcare systems. And then when it came to TI patients and those with mild or not severe strokes, we thought that it wasn't, well, yes, individual processes may matter, but really, it's not like we treat diabetes and not treat the hypertension. So patients getting sort of a bundle of the types of things, the goodies, if you will, to really adequately address risk factor control. And then we calculated without fail rates for 6 of these processes that we see here in terms of imaging of the brain or the carotids, blood pressure medication, being on the right statin, and then antithrombotic agents. So first in mortality. So we'll see that when looking at 90-day mortality, everything except anticoagulation for atrial fibrillation was associated with improved 90-day mortality, and these individual processes were associated with all of them were with improvements in 1-year mortality. So that was really satisfying. Some of the next set of analyses in terms of looking at recurrent cerebrovascular events was a little bit satisfying in terms of not one single row or one single healthcare process was not associated with reduced risk of recurrent stroke, even after adjusting for multiple comparisons. So then we wanted to say, okay, well, let's examine a bundle of these quality measures to see their impact on a potential impact on outcomes. So without fail rate, meaning that patients got all the goodies for these 6 processes of care, didn't occur that often. So 15.3% was sort of the mean facility rate, average in terms of getting all the goodies that they're supposed to. But when without fail care occurred, there was almost a 31% reduction in 1-year mortality. Didn't really seem to, the without fail rate didn't really seem to be associated with 90-day mortality, and it also wasn't associated with recurrent cerebrovascular events. But the idea that at least with these bundles, we are able to sort of improve post-stroke mortality, especially the longer term. So through some of the big data and little data, we started to get a good sense of that we've been able to develop systems that would allow for transparent reporting of care quality, as well as something that could help inform sort of intervention work. So in a query-related project, we wanted to implement a protocol-guided rapid evaluation for patients with new transient neurologic symptoms, because every study needs a good acronym, right? So and this is what sort of a stepwise trial looks like, where here we weren't recruiting at the patient level, we were recruiting entire sites, and we went into the site to help them improve their care delivery. And we did that, one of the themes here is bundles. We did that with a bundle of different programs. One had to do with clinical programs, where drawing from Dr. Bravada's expertise, my own and the team's, developing pharmacy protocols that could be implemented at discharge and post-discharge, developing tools to identify patients that have had a stroke or TIA, helping sites develop rapid access clinic for people that were discharged from the emergency room. We did a lot in terms of professional education, in terms of videos, handouts, as well as things that could be directed at the providers as well. Like I mentioned, there's EHR tools, quality improvement support, the use of sort of Lean Six Sigma personnel to help them understand the current state and retool workflow and look for barriers. But then we also had created a dashboard that allows for site-specific evaluation of TIA and ischemic stroke performance data based on the electronic quality measures that we had talked about. So this hub is up, it's available, and I'll get to the fact that it's available to everyone. But through this, sites were able to look at their own individual care quality, look to see what their without fail rate was, and then being able to say, identify individual processes that they probably weren't doing as great on, that would be really amenable to some quality improvement work. So, for example, here, looked at a higher monoamine potency statin, where it's about 73%, but people were being discharged more than 90% of the time on a statin. It just there's still room to go in terms of discharging them on the right statin. So this was looking at what we did in West Haven back in fiscal year 2019. So it's always a little sombering too when you sort of see how you're doing compared to the rest of your 1A VA medical centers. At the time, we were 96 out of 124. But we were able to say, okay, well, there's something that we're doing a pretty good job on in terms of anticoagulation, thrombotics, brain imaging, but there were areas where we could definitely improve on in terms of carotid artery imaging, as well as being able to get people on the right statin and looking at hypertension control. So, and this was sort of a breakdown in terms of the not just the composite of without fail rate, but being able to see where are the things that we could really sort of perhaps get really a lot of bang for the buck. One of the other things that came up was how can we get patients into primary care visits sooner rather than later, seeing that a little bit more than 40% only had a PCP follow-up within 30 days. So we developed this infrastructure, and then we went and we helped 6 different medical sites at different time points to be able to use these data, use the tool that we developed to improve care quality and delivery. We expanded it the without fail rate to 7 guideline recommended measures, one of them with addition of neurologic consultation. And then from there, we wanted to get a sense of, could we help with the processes of care? Could we measure those, understand the without fail rate, and seeing if we were able to understand what their baseline or their current state was before intervening. So sort of across the 6 VA medical centers that participated, their without fail rate was anywhere from 37 to 54%. So after the intervention. So as you could see here in green that we were able to move the needle on all the sites in terms of improving their without fail rate. What this actually ended up doing was an unadjusted analyses that improved the 90-day mortality rate, as well as also improved the 90-day stroke rate. So it was really fantastic to know that we were able to move the needle, not just for individual patients, not just for that one N of one or those N of ones that we see in clinic, but the entire ends of one's entire healthcare centers. So based on the success of the project, so these resources were available nationwide, and we started developing and deploying teams to go to VISNs that looked like they needed more help. So we initially started in VISN 5 and part of VISN 6, and things that had slowed down initially because of COVID, but we're relaunching those. But it was really fantastic to see that we could go from using big data as well as understanding what are some of the things that we could develop using little data, provided feedback to help develop interventions that by proof of concept worked at 6 sort of very representative VA medical centers across the country. And now those same types of tools and resources are available nationwide, which is really fantastic. So as Chris mentioned, sometimes it does appear that my interests are a bit schizophrenic. So we talked about stroke and TIA care, and we know that tends to be one of the most disabling neurologic conditions of older folks. Now, thinking about disabling neurologic conditions for younger people in the most productive years of their life, and that typically being a headache and migraine. So really sort of thought about, are we able to adopt some of these learning healthcare system principles to improve headache care quality and delivery? So even before I started thinking about this, some other people started thinking about this as well. So these are 2 headache neurologists. Tisha Monteith is in Miami and Bob Shapiro is in Vermont. And so Tisha was the 2009 American Academy of Neurology Advocate of the Year because her advocacy plan was developing a VA Headache Centers of Excellence program. So Tisha and Bob know each other well. So Bob had picked this idea up and really sort of ran with it. And it became one of the advocacy asks for Headache on the Hill, which was modeled after Neurology on the Hill. And it would eventually lead to getting a multitude of congressional sponsors, both on the House side, the Senate side, as well as being bipartisan. And in 2018, the concept of headache centers of excellence came to pass in the form of the Military Construction via Appropriations Act. And part of the Lord of this was recognizing that many veterans will have had a traumatic brain injury because of defending our country during the global war on terror, and that many veterans develop either post-traumatic headache or may have developed chronic migraines during this time. It also had noted that, across VHA, at the time, there were only 3 UCNS headache medicine board certified folks, why I was one of those 3. So Congress had really said, listen, and noting that the VA has successfully created other neurology centers of excellence programs. And I know folks that are quite familiar with the epilepsy centers of excellence program, that something very similar should be done for veterans with headache. So initially, when we started out, we had 7 sites. They were aligned fairly closely with the polytrauma centers, as well as one in Cleveland and then one here in West Haven. Part of the initial congressional memo also had embraced the learning healthcare system tenants to say, okay, well, yes, we want you to create this national program. We want you to start off with this many sites, but we also want to be able to understand things that you didn't see mentioned in the appropriations language. Meaning it didn't tell you anywhere how many veterans with headache there are, how many veterans with TBI and headache or post-traumatic headache. It didn't tell you any of that. So really being able to understand things as foundational in terms of incidence, prevalence, care quality, where veterans live and they're getting their care. None of that was known, but that became part of the Centers of Excellence program. So in some ways, it was really fantastic. So instead of kind of working small and then going to something that became nationally deployed, like the PREVENT program, this started off fairly large and part of a congressional mandate, but was really a great opportunity from the get-go to incorporate these tenets of a learning healthcare system, and really being able to draw some of the strength of VA data to be able to inform and understand how the VA is doing in terms of delivering care. So next, we're going to focus on some of the things related to the structure and processes that we've been putting in place, and what's been some of our growing understanding of headache among veterans. So again, sort of going back to understanding how we could go improve care delivery for that N of 1, and recognizing that there's a whole lot of veterans with headache here. And really, if you're in any kind of general neurology clinic or more in headache clinic, you're going to see veterans with headache. And let's face it, as neurologists in training, like, we see headache. That's a large part of what we do. So one of the things that we did from very early on that took us some time is we built what is actually now considered the world's largest data set of patients with headache, not just veterans, but patients. It's part an operational data set as well as part research. So we get our data refreshed every quarter. So we actually have complete FY 2021 data. Going to report the data up until 2019 because there's a bit of a lag in terms of the comorbidities. But during this chunk of time, more than 1.5 million veterans were medically diagnosed with a headache disorder. When I say medically diagnosed, that means that veteran thought enough to talk to a healthcare provider about that headache, and that headache put an ICD code in their medical records. So this is a little bit different than doing sort of a random sample of surveys. So these are veterans that sought out and received medical care in VHA for headache. So I bring that up because it does build in some potential selection bias, meaning that these are the patients that had severe enough headache where they wanted to talk to their healthcare providers about it. From a healthcare system perspective, because these are the patients, the veterans that are getting care in VA, these are the ones that particularly they matter. But there's definitely ways to sort of get at understanding if there are more veterans, and I think there are lots of veterans that, based on just ICD codes, are getting care in VA that we could do a better job identifying and treating. But still, 1.5 million is pretty impressive. That equates to about 14% of the entire veteran population getting care in VHA. And we know that most veterans actually get about 1.5 different headache diagnoses, and we'll get to that in a little bit. But then during this time, there were more than 8.2 million individual encounters, primary care providers, neurologists, emergency medicine, physiatrists, women's health clinic, urgent care, where people came and got care specifically for headache. So with that said, we have had and continue to have a lot of information, a lot of N of 1 to really understand, basic epidemiology that could subsequently help us further understand a headache in the VA. So not surprisingly, most veterans getting care in the VA with the headache diagnosis are men, and the men tend to be older than women. There's actually this really interesting sort of bimodal distribution in men that we don't see in women. In women, it tends to mirror the distribution that we see for migraine headache in community or private sectors. Typically, most men tend to be white, more often to be married, more often to have TBI, and then also more apt to have PTSD, as opposed to women getting care with migraine that were more often Black and had a very large rate of military sexual trauma. So so in this analysis, we didn't have a matched group for women without migraine or women without headache. We have that now, but to give some kind of indication, typically you'll see, or what I've seen reported in the general veteran population for women is a range of military sexual trauma between 25 and 29%. So apart from some of the demographics, what are the diagnoses that people are getting? What are the headache diagnoses that people are receiving? So like I mentioned, that most people will get more than one headache diagnosis, and we'll get to that in a bit. But the most common diagnosis that's coded is headache not otherwise specified. So and men are more likely to get that than women. And then men are, when men do get a specific headache diagnosis, they're more likely to have post-traumatic headache, and not surprisingly, they're more likely to have cluster headache. I should make mention, in our cohort, we have 29,000 veterans with cluster headache. So it's been really exciting because this is considered by NIH to be a rare disease. So we have the largest cluster of cluster headache patients. Also, when men get diagnosed with headache, they typically only get one diagnosis on average. As opposed to women, they're much more likely to get migraine as a diagnosis. They're more likely to have more than one headache diagnosis, and they're more likely to not just on average have more than one, but have multiple headache diagnoses. So next, we want to ask, using stop codes, where are patients with headache getting their care in VA? And I guess not surprisingly, an overwhelming majority will get it in primary care. Also, men, when they do get headache care, they're more likely to also get headache care from a physiatrist. And I think that also goes along with the traumatic brain injury history. But when men see people, providers for headache care, they're on average, or for the most part, they're really only seeing one provider for their headache management. And if you sort of combine that with information above, they're typically seeing only primary care for their headache. So women, in comparison, they're more likely to see a neurologist for the headache. They're more likely to see someone in a pain clinic. They're more likely to actually get headache managed from psychiatrists as well. And you'll see sort of overall sort of higher rates of emergency medicine utilization, and that women tend to use the ER more often than men. And then they're more likely to see more than one type of provider. So women tend to get more specific headache diagnoses, and they're also more apt to get more headache care than men are. Men, in comparison, more likely to get just a generic headache, not otherwise specified, unless it has to do with unless it has to do with a traumatic brain injury. So we're looking at data on millions of people across many more millions of encounters. So we definitely try to think about how to, again, bring it back to those individual patients and those individual patients getting care within healthcare systems. So next, one of the things that we did was that we wanted to understand where veterans were getting care within VHA. So this is a bubble map. So it's the United States, and every bubble represents a medical center, and we'll be updating these maps in a bit. But the bigger the bubble, the greater the density of patients with headache. So you could go in this portal, you could click on a given bubble, and you can see how many veterans with any type of headache disorder are there, what are the rates of emergency medicine utilization, neurology utilization, who gets guideline concordant migraine therapy, who's on sort of bad medications, if you will, if you're on Alfuroset, and then also what's the rate of opiate utilization for headache as well. So kind of moving to the Pacific Northwest, when we look at some of the data from via Puget Sound healthcare system, sort of across the board, most patients overwhelming majority are seen in primary care. So that, I think that skews some of the numbers that we see, that almost 70% get a diagnosis of a headache not otherwise specified. A little bit better than parts of the national average, where more than 25% you get to be seen in neurology. And not surprisingly, when people are seen in neurology, they're less apt to get a very non-specific diagnosis like headache not otherwise specified. So we've sort of built these dashboards and made them available to Mike and Peggy and the headache centers of excellence across the country to start understanding more about the patient that they're seeing in their own medical center, also their patients in the VISN or any patients across the country. One of the things too, when we built this infrastructure, we also wanted to get a sense of not just what type of provider the patient was seeing, but how they were being seen. If it was in person, was it over VVC? Was it over clinical video telehealth, which is telehealth where typically a veteran has to be at another medical center or a CBOC slash community-based outpatient clinic? Were they seen sort of face-to-face? Was it a new patient, or were they seen in the emergency room? So here are some of the national trends in terms of headache patients during the pandemic. So some of the things that we see in February, where rates of telehealth sort of across the board was, VVC were fairly low, and CVT was definitely the preferred telehealth modality seen in the yellow line at the pandemic struck and went across the country. Yeah, again, because CVT required a veteran to leave their home and come into some kind of VA facility to get telehealth, we see those numbers sort of declining. And then we see a really sort of sharp rise in VVC, or VA Video Connect, where telehealth to where the veteran is, and typically their home. So the numbers went from a couple hundred to several thousand, and really sort of helped to offset some of the lack of face-to-face visits. So, and on the dashboard that we've created, not only could we do this not just sort of nationally, but then also for individual medical centers. One of the things that we're building in now, but we've analyzed, is that there are very interesting sort of healthcare disparities when it comes to telehealth delivery for veterans with headache. So people that are older are less apt to use either VVC or CVT. Since then, we're in the process of adding the telephone codes, but their older folks are less with headache, are less apt to get telehealth for their headache, and they're more apt to use telephone visits as opposed to people that are younger. Veterans that are Black are less likely to engage in VVC or telehealth. Veterans that are Hispanic are less apt to engage in VVC compared to white. And then, so Hispanic uses it less than non-Hispanics. One of the other things that was really interesting was that there was a huge uptake of VVC for telehealth among those veterans living in a urban area as opposed to rural. And those of us that practice in the VA, we know that there's a strong push to increase access to veterans in rural areas, but the uptake was much sharper among the veterans living in urban areas. And for those of us that follow what's going on in telehealth, sort of, in non-VA healthcare systems, and understanding what Congress and the president are trying to do, recognizing that people in rural areas may not have access to great broadband or connectivity. Here in VISN 1, I have veterans that live near the Canadian border that they have to travel 100 miles just to get access to Wi-Fi. So, and this is what, again, going back to Puget Sound, in terms of what the VVC utilization rate and face-to-face visits looked like for sort of very early on in the pandemic, where you see that VVC went from like some patients to a couple hundred patients pretty early on. And I should make mention, in FY 2021, these numbers continue to climb. So again, we built some data systems so that that any one medical center could go on to see, learn more about their patients, and then and I'll share like some of the areas that we're going to next in the next couple of months. But again, how do we help the one medical center help the one patient? We ended doing about 80 different interviews of veterans getting their care in VA facilities, and some of the things that we learned in terms of the that patients really wanted their providers to understand how disabling the headaches were, how isolating the migraines left them, but then also recognizing that it was important that that listening was part of the headache plan. And some of the things too, in terms of just, again, their preferences for telehealth or getting any type of care, so that's convenient for them, that also didn't bring about headaches. So I know we're almost at time. So some of the things that we learned too for healthcare providers was what it means to be a headache center. And some of the things here that should be routinely offered that we learned from the Stu Teppers of the world, if you will, in terms of neuroblock, neuromodulation, having headache trained physicians was deemed to be hugely important in setting up headache centers. But then also, I think that would be great to have, but maybe not be necessarily available on site, also included having health psychologists, infusion centers, patient care navigators, and the use of complementary and integrative health services. So some of the things that we've been trying to do within the headache centers is we learned that headache is very common. There's lots of opportunities for growth as well as quality improvement in terms of diagnostics and treatment, but that telehealth can be used well and used rapidly. And that sometimes from patients, we heard that bundles of treatments and care that resonate with the values and preferences was really important. So some of the things that I think are important is that headache center of excellence have access to all their dashboards, so they have access to data about their patients. And then we've implemented national training programs for primary care providers and other healthcare personnel in terms of diagnosis and coding. And then some of the things that we'll be doing in the next 9 months or so is to the headache center is making widely available an iOS app that veterans could use for headache diary data. It's also part intervention because it gives prompts in terms of helping to do self-management. And then those data will also appear on the dashboard as well. So we'll be able to use patient-reported data in terms of disability, interference, and headache days to understand how headache is impacting their life, but hopefully the impact of our treatment. So in this role, one of my bosses is Congress, so I usually have some kind of congressional briefing to give every other month. And one of the things that going to be very new for this year that we'll be expanding. So over the last couple of years, we went from 7 sites. We were able to include Mike and Peggy there. So, and now we're at 19 sites, and we'll be growing even more this year, as well as providing additional resources for all the existing sites. So I really want to thank you all for your time and attention, and maybe I'll pause and see if there's any questions.
Thank you, Jason. That was really interesting to hear all the work you've been doing, and Larry Brass would have loved this, and be happy that you're working in the VA, and I am too. One thing that popped out, and this kind of, I often have opportunity to roll out a Larry Brassism or some Larry Brass wisdom when I'm attending. One thing Larry used to always talk about is that ER doctors are actually really good at diagnosing stroke. When I tell that to neurology residents, they sometimes are like, oh, are they? And it popped out in one of the data slides he showed for quality measures, the 60% fail-free rate, the lower group, one was not having a neurology consultation by day 1. And were you able to get more granular? Were all those sites placed that have 24-hour neurology coverage? Why was that? We still see occasionally, a patient ends up getting admitted to medicine that were consulted on the next day that clearly had a stroke. And I don't understand why that happens.
Yeah, so some of the analysis that we did in terms of where we had the data. So if sites had, a neurology service versus they had but most places had a hospital service with a neurology consult. And it actually didn't even matter so much in terms of like the complexity of resources necessarily. But when a neurologist was not involved, the without fail rate was much worse, and the outcomes was much worse. So we haven't done anything in terms of like specific chart review to understand some of the reasons why. One of the things that we did with administrative data is that when a neurologist was involved, patients are more likely to get individual parts of the bundle compared to when a neurologist was not involved. So even if a neurologist is, with a neurologist serving as a consultant, making the recommendations that we all sort of make or we do when we're seeing patients. Just I think the neurologist being involved and talking to the team and saying these are the things that the patient should get, based on the fact that they've had a stroke. That seemed to be really adequate and very important for patients to get the type of care that they needed, even care at discharge. So being able to say like, getting a moderate or high potency statin by the time someone got discharged, for example. So it was, so it definitely, so having a neurology consultation was associated with higher rates of better performance on each of the individual measures.
Great, thank you.
Jason, hi. Thanks for the interesting talk. I had a question about quality metrics in the VA system. I was noticing some of the things that you were tracking with the data. How much does the VA system interface? This is my ignorance. How much does it interface with existing quality processes? And for stroke, I was thinking about with the guidelines, for example.
Yeah. So even, for example, like when you look at some of the authors that are on the AHA-ASA, the acute stroke guideline, the prevention guidelines, so the ones that sort of outline what these quality measures should be, they typically have like several VA folks. So Dawn is on there, Mark Chimowitz, who's at in Charleston, Linda Williams. So, and when they have VA representation, they do try to make it really broad so that it's almost like it's healthcare system or healthcare center agnostic in terms of being able to offer or being able to say like this is the evidence behind each of the individual electronic quality measures. One of the things I've done sort of on the Yale side is help them incorporate the electronic quality measure that we developed on the VA side for, and Yale New Haven is on Epic. Chris and I remember when it was handwritten notes, a long time ago. But yeah, so these electronic quality measures can readily, equate to other electronic health records. So in wearing my AAN hat, have helped the AAN Axon Registry folks sort of take these electronic quality measures and get them into the Axon Registry. So they're quite portable. So they're rather agnostic to the EHR platform.
And Jerome Graber had a question in the chat box, which is a good follow-up to Bay's question. And it's when implementing recommendations at the population level, how do you still preserve patient autonomy in choosing or rejecting recommendations without punishing the provider for not meeting the standard, especially with culturally competent care in different populations?
Yeah, no, absolutely. I think, so thank you for that. That's a great question because, so a couple thoughts. So a year and a half ago, I was the lead on the AN general neurology sort of quality measure set. And, it becomes this balance when we're trying to go from like that N of 1 to the N of like 1 million or 2 million. And, especially in this, so especially in a day and age where healthcare systems are becoming more and more data driven, how do you, I think one of the questions is how do you define quality? And so you could talk to a patient about, yes, I think you should be on a high, moderate to high potency statin, but they may say, geez, you know what, I read here that statins are bad and I don't want to do it. So, if you look at just sort of like the data in terms of like numerators and denominators, it looked like that person, that patient failed that metric, and correspondingly, that provider failed to give the best care. So from like a population perspective, that's why a lot of these sort of without fail rates, they'll give like the cutoff of like 80% plus. But I think when it comes down to sort of individual patients and individual discussions, how do you not sort of ding an individual provider for offering something, but if someone does, like if a patient doesn't want it because it doesn't resonate with his or her values and preferences, they're not going to take it. So I think, and then also, that taking into account cultural backgrounds is so huge. So I think one of the things that I try to remind myself is one, are you looking at it at a population level versus that N of 1? 2, recognizing that there are limitations and that pass fail on a quality measure a single quality measure is not a way to sort of judge care for an individual provider. I think some way that it's also that becomes also nice too when you look at a bundle of things, because someone may not want a statin, but they're fine with getting their blood pressure control and getting a head CT, et cetera. So I think in some ways, the looking at things as a bundle, which we see is associated with improved outcomes, is also another way by which it sort of helps to dilute, like if one of those measures are sort of failed, if you will. But then also something that comes up too is risk adjustment. So if you look at some of the original papers that looked at outcomes, if a stroke patient went to a Joint Commission certified stroke center versus a community one, it looked like there were worse outcomes when people went to a Joint Commissions one, but really that's because those centers were seeing like the biggest, baddest strokes. So in terms of being able to risk adjust for any disease severity, I think is important. So for example, when I see patients, when I'm wearing my headache hat in the headache clinic, I'm seeing patients that have headache all the time or pretty much every day of the week. Like they're not someone that you give them a triptan once a month and they're doing great. So I think that the quality measures are important to look at in terms of like larger healthcare units, if it's like a firm or entire medical center. But I agree, like when it comes to individual providers and individual patients within providers, we're not going to be able to have everybody pass all of our measures. I mean, there's some patients in my stroke clinic where I cannot get their blood pressure below 140/90. And so for that patient, it looks like I'm a bad provider. So, but there's things in terms of like disease severity and patient preferences and values where I think that it's important to like have caution to sort of overly interpreting that, a quality measure absolutely means that good quality for a distinct provider giving care to a distinct patient. But it's tough. One of the biggest critiques that we had with and quality measures was, one, how could you implement it on a larger scale? And then two, just because an individual patient may, fail, it's something that construed as an individual provider failing. So it becomes tricky. And I think that quality measures are one way, but it's not the only way that we should measure quality.
Well, great. Thank you so much, Jason. That was wonderful to hear about all the work you're doing, and thanks for advocating for the VA and these patients in Congress. That must be an interesting experience. I don't know if there's any fun things you can share about speaking to our congressional leaders about headache.
Yeah, sound bites.
Yeah.
Sound bites, bullets, and yeah, and it's in many ways like the great work that we do in the VA and the headache centers makes my job easier in terms of being able to share, the thing that veterans share with us in terms of the care that they're getting. So in some ways it's great because I get to brag, but also get to say, look, there's so many more millions of veterans that we never knew had headache. And those data have directly led to the expansion of and what will be the continued expansion this year with the national program. So it's really wonderful in terms of being able to share the good news and also speak a slightly different language on the same topic to elected officials.
Yeah. Well, fantastic. Thanks again for your time and speaking to our department about your work.
Great. Excellent. Thanks, Chris. I really appreciate it. Rusty, it was wonderful to see you again also. And I'm happy to stick around if other people have questions or comments.
Okay. See you, Jason.
Okay, great. Bye-bye.
Cheers.